Welcome to these lectures about children living under time of war and crisis. My name is Helen Christie. I'm a psychologist, and I've been working with children exposed to abuse, to violence in my own country, and I've worked very much in war-affected countries with children and grown-ups who live under extreme stress or in actual wartime. Now in Ukraine, many children and families are living under major stress, and some have also experienced quite serious traumas. So on behalf of mental health and human rights, I've been asked to make a series of lectures about children, how they react and how we best can assist them. So together with some colleagues that will come in later and present themselves, we have made this into 7 parts. First, an introduction, and where we are talking in general how children react to trauma and major stress situations. And then we go deeper into each level of childhood, the 0 to 3, the 3 to 12, and the 12 to 18. So my colleagues will also assist and give lectures about what's specific about these stages. And then we will talk about how parents best can assist their children, and what we as helpers can do for helping the parents to help their children. And then we will also talk about how can the school and the teachers be of help for the young people when they are living under such major stress. And least, we will also talk about, as helpers, we sometimes get burned out because we are listening to such heavy stories, we are experiencing trauma ourselves or loss, and it is important for a helper to also take care of herself. So that's the last part. So, but we start now with the introduction. We somehow differ between living under major stress, which I think all children in Ukraine do nowadays. There is anxiety, uncertainty, it's separation and sorrow because it's a lot of losses. There's big changes in the daily life. Many people are fleeing not only abroad but also inside Ukraine. And there is also for children the very strange feeling that the grown-ups are not behaving like they used to do. So it's a lot of stress for, I think, almost all children in Ukraine at these times. But then there is also someone who are experiencing trauma events. And being exposed to trauma events has some specific reactions. It's an overwhelming feeling. It's a lot of confusion. It's that sometimes, in theory, they say that sometimes the most scary thing is not only what you see, what you experience from outside, but that you don't recognize yourself. You feel you are different, you behave differently. So let's go into the trauma part a bit. The definition, the very definition of trauma is that it's being exposed to an external event. In that way, it's different from the concept of crisis, because crisis can be something in your personal life that's different from you, or you and me react differently to what we experience as a crisis, but an external event that would be serious for almost everybody, that has the element of a threat, of physical or psychological, a threat towards physical and psychological integrity, or that you are witnessing to someone close to you being exposed. So I think many children also are not traumatized because they have directly experienced trauma, but they have been witnessing something happening to their parents or to their siblings or their friends or grandmother or whatever. And that is also seem to have the same impact as if you have been exposed yourself. So how do we react when we are exposed to trauma? Janina Fisher used to say that trauma survivors have symptoms instead of memories. We don't always carry clear memories of what we have experienced, but we get a lot of different symptoms. It can be all kinds of symptoms, from depression, from psychological symptoms to physiological symptoms. So, and the trouble is, in a way, that it doesn't have, it's not specific for trauma. I mean, you get depression from other things as well. And you get stomach pain, or you get social anxiety or whatever from other things. So it's similar to many other stressors. We usually say that some normal reactions to trauma is that you have these physical complaints. You have, in children, very often separation anxiety, sleeping difficulties, increased aggressive behavior and angry feelings. You have constant worry about possible danger. You see that the children are alert, they are looking for danger. They lose some learned skills. That's a very important and very significant reaction, that you see that children somehow go back in what they have learned about how to speak. They start bubbling like they were babies, or they lose their speech, their words, or they start bedwetting again, etc. So they lose acquired skills. You can see sometimes a withdrawal from other people, but also from activities that they used to enjoy, and lack of interest or feelings about anything. They seem somehow indifferent. And they seem to be restless and not being able to choose or to complete an activity. And they have trouble concentrating. So for instance, teachers and in school, you will see there are a lot of learning problems connected. We usually say that trauma consequences are mostly into three categories. It's the re-experience, that you don't only memorize what you have experienced, but that you seem to relive it. It can be flashbacks that is caused by triggers. I will talk more about what we mean by the word trigger, reminder. And it comes very often back in during the night, in your dreams, in your nightmares. It's one kind of re-experiencing. And then you have somehow the opposite of re-experiencing. You have the avoidance. You don't want to remember, you don't want to talk about it, you don't want to see anything that resembles it. You don't want to get near places where it happened, etc. And then you have the third category, which I'm also going to talk more about, which is the hyperarousal, that you are more activated in any way. You are easily irritated, you can't fall asleep, you are startled, etc. We differ between PTS, which is post-traumatic stress reactions, which is normal, and PTSD, which is post-traumatic stress disorder. Because if it lasts longer than 6 months, if it's very severe reactions, and if it increases, then we say perhaps it has developed into a PTSD. But the reactions I have talked about so far, the re-experience, the avoidance, the hyperarousal, is not necessarily a psychological disorder. It's normal reactions to abnormal circumstances. So I said we will go deeper into this, but we have to look for age-specific reactions. We have to see that the reactions in babies in 0 to 2 or 0 to 3 are much more connected to attachment, their attachment system. They are starting clinging, there are separation anxiety, they have lost the little capacity they have to regulate themselves. You can see eating problems, sleeping problems, etc. And into the next stage, preschool children, you also see this clinging and separation anxiety and food and sleeping problems, but you will also see that their capacity for play is changed. Some become more passive and helpless, and also for these children you see that acquired skills are reduced. In school children, you will also see that their play is being changed. You get a lot of repetitious play, that they repeat again and again what they have experienced. It's not abnormal. We know from daily life that if you take a child to the dentist, they go home and they play that they are the dentist with their doll. So repetitious play is not dangerous, but it can be very rigid and not with any variation. And you can see more aggression and more restlessness in the school children, and that they have learning problems. But you also sometimes they experience and they express their trouble by having somatic explains. That my stomach hurt, my head, I have headache, and very not concrete but very diffuse somatical pain. In teenagers, you have the very classical PTS symptoms. For some, you have inappropriate sexual behavior, especially if they have been exposed to sexual abuse during war or been witnessing this. And then you have the guilt and shame, nightmares, and impulsivity. I'll just talk a bit more about play because it's a very big interest for me to see how, because play is such an important part of children up to 12. The play is where we explore the world, where our imagination is unfolding itself. Play is also where we experiment, but play is also that we process what we have been through. So play is the most valuable natural capacity that a child has. But unfortunately, the most valuable resource is also the one most vulnerable. It's valuable and vulnerable. And for some children, you see that the capacity to play can be totally lost. They can't play anything anymore. I have seen a lot of refugee children who have lost really their capacity to play. Or the next level, they do play, but they play rigidly and repetitious and play out hopelessness and it's little fantasy in their play. It's very just repeating what they have seen or experienced. And then the next, a bit better level, is that they play with fantasy. They play with trying out solutions, but it's very aggressive and revenge play. You see a lot of children. I used to work in Gaza, and I saw a lot of children playing war. And then you see also that sometimes children are able to play with fantasy, rescue motives, that someone is there to comfort them, etc. So that you see very much in ordinary children when they have been to hospital, or that they somehow process what they have been through by giving to the dolls or to each other in role play what they needed and didn't get, perhaps. So this is important to have to be aware of what do you see in the children's play. So I'll talk a bit about trauma and our brain. We call it the triune brain. Sometimes we explain to the children it's like a fist. Like this is the old brain, where our survival brain that we have similar to animals. This is the emotional brain. Here the yellow part, the feeling brain, and the green brain is our thinking brain. And when we explain it towards children, we say that somehow when we have been traumatized, our thinking brain is not connected anymore. So it's the survival system, the alarm system, and our total emotional reaction that is dominating. We say that we have a sort of alarm systems that puts us into either fight, flight, or freeze. And that we have together, we have similar reaction to animals. We either we attack back, or we flee, or if that is not possible, then we freeze. And we make ourselves clear or ready for action. We say that when we experience danger, our brain and our body automatically work together in many ways through the alarm system and in the feeling part and in the survival part. That's what I just mentioned. The thinking brain is not included. It's if it gets shut down in a way. And you know, being ready to fight or flight is that if our breathing is very short and we go a lot of blood into our muscles, we are ready to fight. But we also we can also, if that is not possible, we freeze. But this is still a sort of hyper alert state. And if that is not possible either, we go into a sort of playing dead, being quite hypotonic. Like you can see that in animals. You know, you can see how they play dead when in big danger. And some of the same reactions, the shutdown reaction, can also be seen in both children and grown-ups. We have a metaphor that we call the window of tolerance. It describes actually how activated we are. If we are in the middle here, in the window between the two lines, we are awake, we have energy, we have the capacity to concentrate, we can learn new things, we can tolerate different emotions. But when you get hyper alert, when you get overactivated, sympathetic activation in the fight-flight position, you can't really think, you can't really learn anything. You can't tolerate the feelings you have. It's outside your window of tolerance. So this is to somehow give you a picture of how we escalate between overreaction and underactivating. When we shut down, when we freeze, when we really play dead, then it's underactivation. So we use this picture or this metaphor also to do some psychoeducation, both with grown-ups and with children, and say that what we need to do is to help you regulate down. You have to be able to find methods how to calm yourself when too much activated. And then we will come back to how you use breathing, how you use muscle relaxation and different methods in order to calm down, to go down in the window of tolerance. And sometimes if people are numb or frozen, you have to activate them. You have to wake them up. So you have to regulate up if they are too. And then eventually you have to increase the window of tolerance so that you can tolerate being a bit scared, etc. What causes this state? It's not only during the trauma, it's also when you are triggered, when you have a reminder. And reminder could be an external sensory exposure, like something you see. You have been, for instance, exposed to soldiers, and whenever you see a man in a uniform, it's like you are back and you are overactivated again. Or it can be taste, or it can be some sounds, or it can be something in the other person's face that sometimes reminds you. But it can also be just your own inner state. I remember a girl said that running was difficult because then her heart started beating very fast and her breathing was very fast. And then she was reminded of how it was when she had to run from granates in the street. Sometimes we use also another metaphor, which is called the inner wall. I've tried to make a drawing here. I don't know if it makes sense. But, usually we know very clearly what is in the present time and what was in the past. And there I can take memories from my past. Memories, if you ask me about what happened to you last summer, I have some what we call sequential memories that I can take back. And I can tell you, what happened. Memories of trauma are organized differently in our brain. It's fragmented. It's not coherent. And triggers, like for instance a sound that sounds like a bomb or like an explosion, somehow crosses the wall between present time and past time. So it comes in as a fragment that somehow makes you think it's happening now. So in order to assist people who have been traumatized, we have to do a lot of stabilization exercises in order for them to feel, to get the inner wall thicker, so that they can differentiate whether that happened in the past, now I'm in the present, so they don't get confused. I have, together with some colleagues, made a manual called Manual for Stabilization and Skills Training After Traumatic Events. You can download it for free. It has a lot of good exercises. It was not actually developed during a war. It was a big massacre in Norway where 67 young people were shot on an island. A terrorist attack. And we had to work with these young people afterwards, and then we made this manual. So I made this as I've included this in this lecture for you to have some place where you can try to find some exercise that you think could be useful. It's about triggers, it's about sleeping problems, it's about concentration problems. It's not about talking through the trauma. It's about how to help people get more control over their reactions. Welcome back. We have talked about how trauma affects our psychological well-being, but I wanted also to say some very short about the opposite. And it was because I was working in Gaza, and I was teaching about how children were affected by traumas. And it was in a very troublesome time in Gaza. And my surprise was not that children were affected by the trauma, but my surprise was, why aren't even more children even more damaged by living in these circumstances? I couldn't really understand. And I thought, some of them are still playing, some of them are doing schoolwork very well, some of them have good relationship to their parents and siblings. And I thought it must be something else inside our human psychological functioning that is the opposite. And then I met this concept, resilience. Resilience doesn't mean that it's only inside a person. It's some characteristics about our constitution, our robustness, or our previous experiences that makes us more or less vulnerable. But it's also, resilience is really a concept about an outcome, that you have a positive outcome despite having been exposed to very serious matters. So it's factors inside a person, it's factors in the family, it's factors in the society and in the culture. We have a concept called the protective shield, which is that for children, it is sometimes not the event, but whether there is a protection present. Whether we know from literature that under Second World War, that the children sitting in the basement on their mother's lap when the London was under bombing attack, they were less damaged than those who were separated from their parents and sent to the countryside. So for children, that you are here to protect me, even if it's bombing outside, it means the most, actually. And if there is no one there, it affects the attachment system and the basic trust in the world, actually. So some of the resilience factors that we can influence, and some of them we can influence, some we cannot. The cognitive capacity is nothing that we really can influence, but we know that children with a good cognitive capacity and with an easy temperament are more protected. But also skills like creativity, like that they have a feeling of coping, that there is a feeling of meaning and coherence, and what we call internal locus of control, that you have the feeling that there is something that I can influence. I have an internal locus of control. The control is inside me, not for everything, but for something. And we know also that children in families and in their network who has where there is a good relationship before the trauma starts, where there is structure and predictability, where there is rituals and limits, and where there is some feeling of that we belong together and shared values in the society. When I worked in Gaza, I worked together with a professor from Finland, and she said play, dream, and rituals are the three most valuable factors that can protect children. So when you work with traumatized children, do not only look for how they have symptoms and reactions of trauma, but do also look for the resources. What kind of skills does this child have? What is the interest of this child? Is there friends here? Do they have a group that they feel they belong to? Do they have activities that they still like? Because coping, feeling of mastery and coping is stress reducing and stabilizing. And feeling of mastery and coping also creates a better learning position. I said in the beginning that we are going to give specific lectures about each stage of the development, and that is because I've been very much concerned about that we very often talk about trauma as something similar when it happened, because it's not only the trauma, but it's what was the developmental task for that child in that period of life that was disturbed in a way. So I made a sort of developmental model where I put, the different ages on the left side. What are the natural maturity level at how do children meet danger at different levels, and then some resilience factors at different age stage, and then what was the developmental task that the child should master during that period that could have been disturbed. And I'm just going to do this briefly because the films that will follow will go deeper into each stage. So for the little child, 0 to 2, I've called it here, perhaps I should say 0 to 3. I think when a little child meets danger, a high sound or something, they look at their parents to see whether this is dangerous or not. We call it social referral, checking. For instance, I remember when the tsunami was in Thailand, and you went back, some families went back, and they were asked to report what was happening. The grown-ups or the bigger children could tell when the wave come in and what they saw. The small children knew exactly where the mother or father had been in the room, how they looked in the face. So for children, it's what we call social referral, whether the grown-ups seem disturbed and this is dangerous. That is what is most dangerous, scary for the child. The developmental task in this stage is actually, as I have earlier said, it's the attachment, it's imitation. When you talk to a baby or a toddler, it's you imitate the face, you explore, and you start by being able to take the perspective of the others. So if I point to a toddler, 2 or 3 year old, he will not look at my finger, he will look at where I point, the thing I point at. That we call that they can take the perspective of the other. So if trauma, if a 0 to 3 year old is exposed to trauma, we think that one of the risk factors is that you can have an attachment disorder, you can have an insecure attachment, clinging, or you can have this disorganized behavior that doesn't really know where to seek when in danger. When they have what we call regulation disorder, it's easy to calm them down. It's not easy to calm them. It's difficult to calm them down. It's difficult to make them fall asleep. It's difficult to get them to eat regularly. So that is especially for the youngest. And then you have the early childhood and the childhood 6 to 12, where this play is such an important developmental task, because play helps them also to start self-regulating and to think what is behind. Mentalization means to think what's behind behavior. So we see that during the period, if I take the group 3 to 12, you see that the emotional regulation, being able to calm themselves down, to play, to mentalize, and to feel this internal locus of control, this self-efficacy that I master, can be really affected. And the older they get, the more you can go into a social behavior and mistrust to adults and mistrust to oneself and others, because in that period, I think you all know, if you meet a girl 10 to 12, what's the most important thing for her? It's to be similar to others. It's to have this peer identification. And that family is still very important, but they seek out to have friends. To have friends is so important in that period of time. So if this period, the developmental tasks in this periods are disturbed, you easily get this more asocial behavior and mistrust. And then in the adolescent time, in youth, then you should be able to practice emotional self-regulation when confronted to danger, to see whether is this dangerous, to discriminate, is this dangerous or not, and to make some plan. And you should have been able to develop a sort of internal locus of control and some kind of independence under peacetime, I mean. And then you start, the developmental task is to start with this making new intimate relationships, and you are able to find your own identity, and we call it individuation and autonomy, but still related to your family. So it's this balance between autonomy and individuation and belonging. And then during, and I remember very much working with children at this age in Bosnia during the war in Bosnia, that from 12 they were so much concerned about who to be punished for the war crimes, how to get to justice for what is happening now. This was on their agenda. And they also was worried about future. So that is part of, it's an important part of being an adolescent, is that you start wondering and working with these concepts of justice, moral, and what am I going to be, plan for the future. And if this is disturbed by trauma, you very, very often get a poor planning skill. Some of the youth actually, in literature, it's described as they don't have the capacity to think future at all. So you have to help them somehow start imagining that there is a future. Lack of emotional awareness. They don't really, if they are disturbed in this phase of life, this awareness of what I feel, what is me, and what's different from others, can be disturbed. You can have very sexualized behavior, and you can have a fragmentation of your life history, in a way, your narrative of your own history. Sometimes you also see that this concentration about moral and justice and who should be responsible and who should be punished for what I can lead into radicalism and a more extreme political engagement in this period. That's one of the risk factors. So we'll end here. Then we will have one film for each of these periods, go deeper into what happens in that period, how do we see the reactions, and then how can we help and assist children. So our methods have to be according to the child's age and according to what kind of developmental task should be repaired. So, thank you.